A common question that you may encounter clinically is whether or not the QT intervals prolong and whether certain medications may be administered or not. In this lecture, we're going to look at how to determine if it's safe or appropriate to give a patient a medication that may be QT prolonging and how to determine that. Your patient here is a 62-year-old male with nausea. He demonstrates an EKG with ventricular paced rhythm, atrial flutter, and a few PVCs that are there. The QTC is noted to be prolonged by the EKG machine. Okay, so you can see here it's noted to be 442 milliseconds, the QT, but the QTC, which is this one, is 490 milliseconds. Okay, and so the question is, can you give ondansetron, which is Zofran? Okay, there's other situations such as antibiotics that may also prolong it. So we're going to kind of use this approach to see if we can give this patient or not. Okay, so before we get to the answer, let's review some basic concepts. Okay, a normal QTC interval is typically considered less than 440 milliseconds in males and less than 460 milliseconds in females. Although it's not until around that 500 milliseconds that we start to question our clinical decision making. In fact, it's not uncommon for clinicians to avoid important first-line medications and choose less ideal alternatives when the EKG machine measures a QTC interval of 490 milliseconds or just above 500 milliseconds. And as you can see in this patient, he has a QTC interval of 490 milliseconds. So really, questioning, should we give him a Zofran that may actually prolong his QTC interval or not? Now, when there is intraventricular conduction delay, such as a bundle branch block or a ventricular paced rhythm, as we see in this patient, okay, the vast majority of the time, it may in fact not be prolonged. And you may ask, why is that? And that's a wonderful question. So we're going to look at that closer here. Now, first off, we measure the QT interval because impaired repolarization sets up these patients at risk of developing a potentially life-threatening ventricular arrhythmia known as torsades de pointes, which is a form of polymorphic ventricular tachycardia. Now, when we look at the QT interval, we're measuring from the beginning of the QRS complex, which is this point here, to the end of the T wave. So all of this here is considered the QT interval. So think about it. What the QT interval actually includes is ventricular depolarization, which is the QRS complex, as well as ventricular repolarization. Okay, so most of ventricular repolarization is actually the ST segment in this T wave. So all of this tends to be mostly ventricular repolarization. So you have the QT interval consisting of both ventricular depolarization plus ventricular repolarization. Okay, specifically, you can see that the QT interval is made up of the QRS, which is the depolarization phase of the ventricle, and then the ST segment in T wave, that is the repolarization. Okay, and the ST segment and T wave are collectively referred to as the JT interval. Okay, so the JT interval is from this portion here to that. So the JT, similar to the QT, is the ST segment plus the T wave duration. So you can imagine if ventricular depolarization is prolonged from maybe a bundle branch block or a paced rhythm, as we have in this patient, the QT interval may also be prolonged. However, this does not necessarily reflect an impairment in ventricular repolarization, nor a significant risk of developing torsades, that polymorphic ventricular tachycardia. For such reasons, some have suggested actually using that JT interval, okay, because it makes up mostly that ventricular repolarization and takes out that depolarization phase. Okay, but this concept has not really stuck in the medical community. And maybe it's because we've become so accustomed to using the QT interval, and most standards and medication effects are often based on the QT interval. Anyways, that's something that you can think about. Now back to our main issue at hand. How do you adjust for the QT interval in the setting of an underlying depolarization abnormality? In this patient, it's this ventricular paced rhythm that causes slow to slow cell-to-cell depolarization, prolonging that QRS interval. So there's a number of proposed mechanisms, but we're going to focus on one that I think you'll find helpful and easy to use. And now there are three main steps, okay? The first step, you have to ask yourself, by how much is the QRS duration prolonged? And to be safe, you can use an upper limit of normal of 100 milliseconds for the normal QRS duration. Next step, you want to subtract that value from the measured QT interval. Okay, in this step, you're essentially removing the additional ventricular depolarization delay caused by that slow depolarization wave. And the third step and final step is you have to correct the QT interval for heart rate, okay? And in this, we're going to look at Bazette formula because this is the most commonly one used, and essentially it equates the QTC interval, so that C is for corrected QT interval, and you do the QT interval divided by the square root of the cardiac cycle, okay? So we'll look at that. Now, in most cases, you can use this approach and feel comfortable about giving or withholding a QT prolonging medication. If you aren't comfortable, you can always seek more expert opinion from your cardiology colleagues. So back to our case, okay, we have this 62-year-old gentleman, he has nausea, and we're wondering, can we give an antiemetic such as Zofran or ondansetron to this patient? So let's go through the steps that we discussed, okay? There are these three steps here. And the first step is to determine the QRS prolongation. So we have to say, by how much is the QRS duration actually prolonged? Okay, and you want to make this measurement on your own if possible. And remember that each of those small boxes represent, so if you take this here, this small box is 40 milliseconds in duration, okay? It's the width of it. The total from beginning to end would be 200 milliseconds because it's 5 small boxes times that 40 milliseconds, okay? So that's how you get that. So how much in this patient? Okay, so what I've done is I've taken this patient's EKG and I've blown it up for you. Okay, so you can take a look at leads V2 and V3 are now down here. And so the first thing we want to look at is what is the actual QRS duration. Okay, so QRS duration, just so you're aware, I'll erase this here, is from the beginning of our QRS complex to the end, okay? So beginning, the onset of ventricular depolarization to the end of it, or where that J point occurs, which is right here. And what we see here is from beginning to end, it's 180 milliseconds, okay? So the QRS duration in this patient's EKG is 180 milliseconds. And we said that we can use an upper limit of normal of 100 milliseconds, so you do 180 minus 100 and you would get 80 milliseconds, okay? So that's the extra part of depolarization from normal. Now the normal QRS duration is often between 70 and 110 milliseconds. Right around 120 milliseconds, that's when we think things get a little prolonged. But to be safe, we're going to use 100 milliseconds. So 180 minus 100 is 80 milliseconds. In the next step, we want to subtract this number, okay, so what we found was 80, by the QT measured interval, okay? So what you want to do now is measure the QT interval, which we said is from the beginning all the way to the end of the T wave, and if you look here, okay, so from beginning here to the end, and that what we got here was this one here, okay, so 440 milliseconds. So what you have is from beginning all the way to the end, 440 milliseconds in duration. And what you do is take that 440 milliseconds and you subtract it by 80 milliseconds, and that gives you 360 milliseconds. Okay, so hopefully that makes sense so far. Okay, now it can sometimes be difficult to determine where is the end of the T wave, okay, because it could be blurred with maybe the following segment. And one way to help you determine that is by finding the intersection between the maximum slope of the end of the T wave and that isoelectric line. So what does that mean here? So let's take a look at this. So imagine you have your T wave here, so this is our T wave, and you're trying to find the end. Well, obvious, it's clearly here. But what if it's blurred? What you want to do is find that maximum slope and find it, take it all the way down. So in this case, you can see that you can find the maximum slope, it would be there, okay? Same thing in this case, would be right at that point. So that's how you find the end of the T wave. Find that maximum slope and see where it intersects with that baseline, okay? So hopefully that makes sense. Now last, we need to correct for heart rate. And here we're going to use that Bazette formula, okay, which I've put here for you, and that's the QTC interval is equal to the QT interval measured that we got measured, and in this case we said that it was 360, and we're putting that in milliseconds, and we're going to divide it by the cardiac cycle. So if we, from beginning to end of a cardiac cycle. So as you can see in this image here, it's from the beginning of our QRS, we would mark to the next beginning of our next QRS, okay? And that duration is right here, okay? It is 840 milliseconds, so 840 milliseconds. And in this case, you want to take the square root of 0.84, okay? And if you were to do that, you would get about 393 milliseconds, okay? So why is that? Well, you could actually do 360 or 0.36 seconds, so you could do 0.36 seconds over the 0.84 seconds as well, and then get something, but then you'd have to multiply by a factor of 1,000. So either way you can get that. Just know that if you use seconds throughout, you have to multiply it at the end by 1,000. If not, you can use milliseconds on the top and seconds on the bottom, and you'll get this, okay? So anyways, so 393 milliseconds, and we said this is a male patient, okay? Male is less than 440 milliseconds, so we check out there, okay? So can we give this patient the antiemetic Zofran or not? And we certainly can in this case, okay? So yes, we can give it to this patient, and we can feel comfortable and safe about this decision. Now, one final pearl I want to leave you with is while we correct for heart rate and find that QTC interval to determine the degree of repolarization impairment, now the risk of torsades, the ventricular arrhythmia, is actually best approximated by the absolute QT interval and not so much by the QTC interval. Therefore, fast heart rates, which tend to decrease the QT interval, would be seemingly more protective compared to the risk of slower heart rates. Okay, so that's another thing that you should consider. So let's review what we discussed before we end here. Okay, so what we discussed is the QT interval. Remember that the QT interval is made up of the QRS complex, okay, which represents ventricular depolarization, as well as the ST segment in T wave, which mostly represent ventricular repolarization. It's that repolarization that we really want to be concerned about, okay, that impaired repolarization, that terminal portion, because if you have something like a P on T phenomenon where a P wave falls on that portion, you can actually precipitate that torsades de points, okay, that ventricular arrhythmia that can actually be life-threatening. And so what we can also think about is that this terminal portion is actually also known as that JT interval. So maybe that's actually more important, okay, and things that we should consider. Although it really hasn't caught on because most of the way we administer medications and studies have often been done on the QT interval. Now we use QTC, that C for corrected, okay, corrects for heart rate. And normal in males is less than 440 milliseconds and less than 460 milliseconds in female. Okay, remember we measure the QT interval to look for impaired repolarization of the ventricles. Now, one thing we often run into, like in this patient, was that there's a conduction defect, okay, whether there's a left bundle branch block or maybe a ventricular paced rhythm that actually increases the QT interval. So we run into this question like our patient here, the 62-year-old gentleman with nausea, and can we give a prolonged QT interval medication like Zofran, okay? So we have to now ask ourselves, how do we find that out? And we measure the QT by first determining that QRS prolongation, okay? We follow that step. We then subtract that, what we measured, from 100 milliseconds, which is the baseline, and then we calculate the QT measured, subtract that from the QRS prolongation in order to then get to the corrected heart rate, okay? The corrected heart rate we use is that Bazette formula. Remember, you take the QT measured, you can use milliseconds in this case, and divide that by the square root of the cardiac cycle in seconds, and you can get that, all right? And we saw in this patient, it was 393 milliseconds, okay? So this is something that you should keep in mind. It's something that comes up quite often and one that can really be helpful in the clinical setting. Well, that's the end of this lecture. I hope you learned something. Now, just to keep you in mind of our course material that we have available. So again, if you go to our website, www.ekg.md, okay, So this is our website, and what you'll notice is that if you go to the EKG course here, okay, you'll find stuff that's separate. So notice that we have a number of topics, practice material, lectures, a way for you to contribute, and this is the course here over here. So you'll notice we have over 300 videos or so, and that's more on YouTube. There's another 100, more than 100, about 200 videos that are available with the course. So those are separate videos, and this course is really designed to take you from a beginner to advanced interpreter. Okay, so completely separate from what you're getting online for free. Okay, these are course material that comes with it. So notice that you have a book. Okay, and then you also have the pocket guide available, so you can choose which format. They are the same thing, both these book and the pocket guide, different formats. I really like this small one because you can keep it in your white coat if you're in the clinic, or in your pocket, and it's really available on the go. Now with the book, you also get videos. So notice these are the videos, okay? And these are a video for every single page in that book. So it's over 30 hours of video. Now there's a number of practice material that I continue to upload there. Okay, we'll have practice questions coming soon. So all of that's available. Again, this is separate from all the free material that you get already. Okay, so this is more high yield stuff. This is what we used to teach our technicians here and our students here at Mayo Clinic. And it's used now among many institutions. So check that out. Now, what it also includes are calipers. So yes, you get calipers with this course. Okay, I don't know anyone else that offers that, but you do get calipers. I think they're very helpful, and they can, if you know how to use them correctly, can help to identify different arrhythmias that are going on. Okay, and then you also get our pocket EKG reference. Okay, this was something we've put together as we were developing course for the fellows, and this is really nice. It has every code, as you saw earlier, laid out there. Very small pocket guide available. I had help with my colleague, Dr. Peter Noseworthy, who's the head of the EKG lab here at Mayo Clinic, in editing it. So this is something that we use, and we found very helpful. So go to the EKG course. You'll see examples of lectures, okay, why we developed this, okay. A lot of it came about from myself struggling with learning EKGs, having a father that was an interventional cardiologist, and, still struggling. So my struggle is a struggle that I don't want you to have in learning them, okay. You can read all those introductory books, but honestly, they are not enough, okay, and you find yourself using other resources, which is part of the learning process. I wanted to expedite that process for you and make it less inefficient in pretty much what I struggled with going and learning through EKG. So again, from beginner to advanced level with this course, you get the book, the calipers, the coding reference, video access, okay, and now we're offering 25% off. 25% off. Put that code in on checkout, and you'll have yourself 25% off. That will it's pretty much covers the cost of what we use to print the material. So we don't really make much off it. It's more to help our learners grow and really be able to contribute to patient care. That's why we do this, and we love doing it. So thank you so much for your support. If you have any questions, just leave them below, and we're happy to answer them. All right, have a great day.